Okay, we're going to go ahead and continue this video with the palpation of the chest and the lungs. In order to begin this, we're going to go ahead and ask our patient to go ahead and face us. When we do this, we're going to go ahead and use the palmar portion of our fingers to go ahead and palpate both sides of the body at the same time, as we would like to assess the both sides to make sure that the anatomy is somewhat symmetrical, and at the same time be able to feel whether there are any masses, any bulges, any tender areas, anything abnormal whenever we go down the chest to do this assessment with palpation. So we want to start here with the neck area, and then coming down here, feeling the scapula, feeling the intercostal spaces here, checking the sternum here and the xiphoid process, making sure that it does not have any flexibility to it. And we're also feeling for the costral angle here, that should be about 90 degrees, and then feeling these ribs here that are free ribs, not connected to the sternum, all the way down, and also making sure that you palpate the spine, making sure that's rigid as well. Okay, now those are all normal findings. Something unexpected that you would find would be possibly when you are pressing down on the skin and you feel like a crackling feeling. You can also even hear it. That's something we call crepitus. Now sometimes when there is a leak in the lung, some of the air becomes trapped in the subcutaneous layer of the skin, and that is where the crackling sound comes from when you put pressure on it. Now these types of symptoms could actually arise into the area where the leak has perfused, and actually go up the neck and into the face and the ocular area, creating a look that may look very similar to an allergic reaction. So this type of symptom would be emergent, and it would actually warrant something like a chest tube insertion in order to remove that leak. Now, continuing on with the palpation of the chest and the lungs, we're going to go ahead and assess the thoracic expansion. The way that we do this is we go ahead and place our hands at about the area of the 10th rib. When we're looking at the anterior portion of this area, we go ahead and place our thumbs, and I'll go ahead and ask the patient to face the camera. When we're doing this from the anterior portion, we can go ahead and place our thumbs close at the bottom portion of the xiphoid process, just like this, and ask our patient to breathe normally. And then we're going to go ahead and see if our thumbs actually do separate when he does this. Okay, and we can see that we do have a gentle and slight movement of our thumbs outward when he does breathe. And that is just assessing that we do have expansion of both lungs in an equal manner. Now we're going to go ahead and ask him to go ahead and face the other way. And again, placing our thumbs close together at about the area of the 10th rib. We'll go ahead and ask him to go ahead and again and breathe normally. Also looking for the symmetrical movement of both of the lungs, causing our fingers to move away from each other. So we do see this happen in this case. Now we're going to go ahead and, one thing I do want to note is whenever you're assessing the patient, if there is ever a condition where the patient has a pleural friction rub, there may be times that if you palpate with the ulnar portion of your hand, just like this, you will be able to feel, actually palpate a vibration on inspiration, and that is indicative of a friction rub. So that's important to know. But anyways, the next thing we want to assess is tactile firmness. Now, tactile firmness is basically when we place our hands on the back of the patient's chest, right below the scapula, and we ask him to repeat the number 9-9.
9-9.
And say it again.
9-9.
Say it again.
9-9.
Say it again.
9-9.
And then we're going to go ahead and assess him from the front. Go ahead and turn around. Say it again.
9-9.
Say it again.
9-9.
Say it again.
9-9.
Okay, and when we feel this vibration from kind of like the sound waves from the bronchiole going outward, we do hear this, and we do actually want to feel this resonant type of form. And basically a change in that resonance would be indicative of something. For example, if we did not feel the vibration in certain areas, that could be indicative of some type of solid mass, like a tumor that could be present. Or in some areas where maybe there's hyperresonance, they could be indicative of possibility of hyperinflation in that area of the lung, which could be due to asthma, COPD. I mean, there's a couple of things that it could be due to. So these are ways to be able to assess non-invasively for something that could be occurring invasively. Now the last thing that we want to check for after we do this is the actual trachea. Now the trachea on each side, like we saw in the prior videos, it does have a groove here, and we want to actually place our thumbs within that groove and palpate downward. And what we're looking for is to make sure that that trachea is actually midline, because of the fact that if you ever have atelectasis or hypoinflation of a lung, you will see that trachea go ahead and move further towards the area where there is a well-inflated lung. So that would be an indication of being able to note where the lung is actually not working properly, without even having a chest x-ray at hand. Now we're going to go ahead and move forward to the portion of the percussion of the assessment. So we're going to go ahead and start with the posterior portion of the patient. So we're going to go ahead and ask him to turn himself around. Now when we percuss, we want to go ahead and ask the patient to go ahead and bring his arms forward, and then go ahead and bow his head and move in a forward position. This will actually move the scapula outward enough to give us enough space to be able to percuss the lungs. So we always go from superior to inferior and midline to lateral. So we'll start off here at the apex, and then we'll go ahead and mark the area. You want to go about 4 to 5 centimeters within the intercostal angles so that you don't hit bone. And percuss always about the same amount. And then we'll go midline to lateral. Okay, and then when we do this, we're going to go ahead and do it from the lateral portion and the anterior portion. We're going to have to ask him to put his arms up. Now we actually already have done this previously, so we already have the markings for this. But basically, you want to go below the scapula because otherwise you're just going to be hitting bone here on the lateral portion. So go beneath the scapula and start to percuss from there. And then you go ahead and mark just like I have done in the past. And just like we did there. And then we do it from the anterior portion. Okay, and then we're going to go ahead and ask our patient to put his arms down, and then we're going to go ahead and do some more percussion, but this time in order to measure something we call a diaphragmatic excursion. So we want to basically see how much the diaphragm expands whenever we take a deep breath in, and then how much it shrinks or gets smaller and moves up the thorax whenever we exhale deeply. This will be able to give us a good amount of how much flexibility or how much capacity the lung has in order to move air in and out. So basically just another way to determine lung function. So let's go ahead and ask our patient to go ahead and turn around once again. And what we're going to be doing is we're going to go ahead and ask him to go ahead and inhale really, really deep. So go ahead and inhale very, very deep. And then we're going to go ahead and palpate. Where we have already set a line. And then let him go ahead and relax. And then we're going to go ahead and do it again to the other side. Go ahead and breathe in and hold. And then we already set a line where that was. So then we're actually going to do the opposite. We're going to actually ask him to exhale as much as he can and then hold that. But instead of going from superior to inferior, we're going to go from the bottom up to see where we land. So go ahead and exhale deeply as much as you can. Okay, breathe. Okay, and then we're going to go ahead and ask him to do it again. Breathe in and out deeply. Okay. Now go ahead and breathe deeply. And then we're going to go ahead and measure the distance from the point where he had inhaled to the point where we had exhaled. And the excursion should usually range anywhere from 3 to 6 centimeters. So you want to take your ruler and you want to go ahead and measure and make sure that it is anywhere from 3 to 6 centimeters. In this case, it looks like it was about 5.5 centimeters on the right and about 5 centimeters on the left. So we're going to go ahead and stop there with that portion of the video. The next one will be on auscultation.